Okay, this is a listing of the savings that will occur because of the ACA, regardless of any decision the state makes. The first one, collection of rebates on managed care drug expenditures. We have been, Medicaid agencies across the country have been collecting rebates from drug manufacturers for quite a few years. But until the ACA, we were prohibited from getting rebates from drug manufacturers on the managed care portion of our business. And some states even looked at carving out pharmacy from their managed care programs in order to be able to collect those rebates. The ACA changed that. We now do have the ability to directly bill pharmacy manufacturers for rebates connected to pharmacy spending that occurs through managed care. And over the time period that we're looking at, and that took effect in 2010. We didn't start collecting the money immediately, but we had a catch up, and we're getting current now. The total over the entire time period is about $529 million out of the 1.1 or so billion that you see on the slide. There are also savings that we expect to occur because the coverage through the exchange that will be starting up will replace some coverage. Famous Moms Family Planning, some coverage that we provide now. And that will generate savings between those two programs about $60 million over the time period. There's also a small reduction in indigent care at VCU and UVA hospitals that we pay for. Because of the exchange, we expect to see a reduction in the indigent care there. That's about $34 million of the total. There is, during state fiscal year 16 through 19, a 23 percentage point increase in the match rate in the Title 21 or CHIP program, and that accounts for $322 million. Finally, the ACA dish reduction. I mentioned the ACA cost. We weren't sure what to do with this. I'll tell you what we did, and hopefully you'll agree. The ACA directs a reduction in federal funding to states that they can use to spend on disproportionate share hospital payments. And we will see a reduction in the federal funds, and typically when you see a reduction in federal funds, there's a corresponding reduction in state spending. So we will reduce what we spend on disproportionate share hospital payments in the state. However, states are also free to, there are many streams of payment to hospitals. There's dish payments, there's operating payments, there's a number of different things that we pay hospitals for. The state has the option to have an offsetting increase to other payments. The state doesn't have to do that. The approach we took is we didn't think it was necessarily prudent to book a savings based on a federal reduction that the state has the ability to offset in some other way. So we basically showed a cost and an equal offsetting savings, meaning no effect of this particular provision, but certainly other approaches could be taken.